So we're going to focus on discovery and how to discover the need behind continuing education through use of evidence today. Whoops. As well as the learning gap. So everything that really helps you define what it is you need to teach your target audience during a continuing education session. We're hoping to have this session pitched for interprofessional, the needs of many clinical professions. Although I work in the CME office, we also do CE for most professions. Nursing is its own office, but we recently got accredited for social work, the institution did, and then we can get activity level accreditation for almost any profession that requires accreditation. So examples of that include personal physical therapy, athletic training, diabetes education, things of that nature. So who we are, we'll just introduce ourselves. My esteemed colleague, Jack Scott, is our...
I know most of you, I'm Scott in academic affairs. We can introduce everybody.
Yeah, and I'm Rob Martin. I run the CME office. I've been here a year. I've been in continuing medical education since 1998 and continuing interprofessional education since 2007. When I got my employer at that time accredited for occupational therapy. But I'd like to have you all go around and introduce yourselves, starting with Elisa.
Lisa Brinkley. I'm an oncology nurse and coordinate the lung cancer screening program.
Thank you. Joe?
I'm Joe Ragnow. I'm in the Office of Risk Management and Legal Affairs, and I'm a CPH.
Robert Lee, I'm a pediatrician, part of the Department of Pediatrics. I'm the CME planner for the Department of Pediatrics and also CME planner for the Nassau Pediatric Society.
Great. Thank you.
I'm Diana Richmond. I'm a sonographer for maternal fetal medicine. It's our mission that is wanting to start doing presentations and do CMEs for our residents and our other staff.
Great.
I'm Peter Sandry. I'm the CME specialist. I work with Rob in the CME office. I've been here for about 4 years, and Rob and I take care of all the live and RSS programs.
As well as recorded programs, which today is being recorded for on-demand viewing at your leisure later on. So in the spirit of disclosing financial relationships during continuing education, we have nothing to disclose. And just to go over what today's learning objectives are, we'd like you to walk away with the ability to list some of the common methods for identifying a target audience and measuring a learning gap that audience is feeling. We'd like you to be able to make a basic comparison of evidence sources for value of generalizability, relevancy, and are they current. We'd like you to be able to list sources of evidence and where to go to look for data for your needs assessment. And we'd like you to be able to really relate what the principles of learner-centric planning are in a needs assessment and bringing interprofessional perspective, multiple professions into that learner-centric planning. So we'll spend about 30 minutes in lecture with slides, and then Jack and I have developed a worksheet session for you to sort of tune up some of your own ideas that you may have for a new course or an existing course. So we'll cover just what a needs assessment is, what is a target audience and how to define them, what's the learning gap, accreditation requirements, for continuing education, and this is specific to CME, but almost all professions have similar requirements. What do we mean by the learner-centric designation? What exactly is interprofessionalism in continuing education? Why is evidence so important and necessary in the case of applying for education grants. Where is the evidence found? And then putting it all together into more or less a cookbook approach to constructing a needs assessment, 8 steps. And then we'll hit the worksheet with about 20 to 30 minutes remaining. So just what is a needs assessment? First of all, a need would be the discrepancy or the gap between what is or what should be. So between the current state of practice and the ideal state, some people call that best practices versus current practices. But generally, it is a systematic set of procedures that are used to determine and measure needs, to look at root causes behind why the gap exists, and to set some priorities for the intervention, the education intervention. And because you can't really do everything with limited resources. There is never enough money to meet every need. So you do have to use your needs assessment to prioritize and to really drill down on what the needs are. We will be sending out the slides after the session if you are interested in some of these resources we're citing. So just to continue, a needs assessment should be performed prior to the developing the activities. Doing it retrospectively doesn't really work because it sort of it tells you, you already know where you've been, so you're likely to leave a few stones unturned if you do it retrospectively. And most accreditors, myself included, when I have to accredit CME, it's just not good if you don't have a needs assessment. We really can't accredit learning that isn't sort of planned with some sort of an evidence basis in mind. You want to get at what actual practice changes the needs assessment points to, and those can be changes in knowledge, changes in skills, changes in attitudes, and changes in actual practice behavior in the clinical setting. It cuts across many different healthcare providers as well. So the needs assessment should have numeric measures in it so that you can measure, for example, if there are guidelines, practice guidelines from a specialty society that say, you need to be in X percentage of cases, catching this or that diagnosis. And if your local target audience is not catching that, then that right there is your measure. What is the difference between what nationally is happening and what locally we may be doing differently? Once you've identified the gaps, you can then go forward with, how will we plan the intervention? What will we do? How will we use the time we have with the learners to address those gaps? And it's also, a needs assessment is also a way to collect information to see, to help you make that prioritization decision because you can't do everything in a limited amount of time. It also can be very skills-based. Continuing education, at least in this ground floor, tends to be more didactic and knowledge-based, but there are interventions that can be skills-based upstairs in the Sim Center and in other methods to really engage the learners. So what is a target audience? Let's open it up to you all. When you hear the word target audience, what do you think? Any volunteers?
Who the focus should be on.
Good. Who the focus should be on, yes.
Who your primary learners are?
Primary learners, yes. Anyone else? Benefits the most, exactly. So these are the clinicians and practitioners and other learners who have the learning needs. So generally they will have some aspect of a profession that you can point to. often a specialty within that profession or care setting. And then for live activities, there's usually a geographic component, a location. Even for internet-based activities, location may matter. But again, you can't reach everyone. So if you have limited dollars for your education, do you want to focus on, just 5 boroughs or just Nassau County, or do you want to maybe go tri-state or statewide in the case of some of the quality collaboratives, for example, in pediatrics? A lot of that thinking is statewide across institutions. Another aspect that I think Jack mentioned is, primary versus a secondary audience versus a tertiary audience. As Diana mentioned, who could also benefit from this? So, for example, you might have an education that's orthopedic in nature for a specific condition, maybe venous thromboembolism or something in inpatient care. Physicians and surgeons may need that, but you would want to go to a secondary audience for prevention and awareness. And then also you might have a tertiary audience who could also benefit, maybe not as directly, but as part of a care team, they may be part of that. So it's good to segment or prioritize your audience. Again, it helps you make the most of the resources you may have that are limited, and maybe make some hard choices about who not to spend money to recruit with brochure mailings versus who you really would want to get into the seats. So let's go into the learning gap. Now, when we say the term learning gap, how does that strike you? Any ideas from you all? What do we think that might mean?
Deficiency.
Avoid.
A deficiency, a void,
Knowledge gap.
a knowledge gap, the absence of something or a hole. All of those are correct. It's the difference between what currently is and what should be. It's the the road between where we are and where we want to get to. It should be something, again, measurable, and it's the need in the needs assessment. So the learning gap and the need are pretty interchangeable. Needs-based education is a way to plan an intervention, build a bridge, get you to that measure that you can measure by comparing evidence to current practice. Does anyone have any thoughts or questions on learning gap? No? Okay.
Ron, how current does current have to be, information-wise, in terms of measurement?
I've heard people say in the last 5 years, but I think as online publishing is accelerating, I think 5 years can be outdated. So, 2 years, it depends. In certain very subspecialized fields, there is not a lot of research. The tempo of research may limit how current you can use. Best practices are updated periodically from specialty societies, so they're not always annual. But if you should never ignore more recent evidence because it doesn't fit your thesis. If you find more current evidence that changes your thinking, incorporate it. Don't shut it out simply because it's not convenient. So I think most of you got the handouts in email. And so we want to turn to those now if you have them. They are the ACCME accreditation criteria that at least for continuing medical education for physicians, really spells out the how and why. Criterion 2 really gets to the provider, and the provider in this case means the education provider, not a healthcare provider. The educator incorporates into the CME activity the educational needs that underlie the professional practice gaps of their own learners. So it's really meant to be what they need in day-to-day practice, not what they wish they knew that they wouldn't necessarily use as a priority. So although if they express that, it's a valid need. So that's one firm criteria, and I think there are only about 20 on our list of criteria to satisfy, but criteria 2, very important. Criteria 3 is that really practical component of design to change competence, performance, or patient outcomes. So, if according to our mission, we're doing education that never helps anyone get better, we need to take another look at that. We need to, really look at, well, why are we not changing practice behaviors with our education? What I fondly call drive-by education, where, people just consume it but never use it, and they just want it for certificate. That's getting to be harder and harder to fund education like that through grants, because as it turns out, anytime you get a grant, they want to see what your measured outcomes were for the learning intervention. And those are learning outcomes. They can also be patient outcomes. And if you can't measure them or manifest some evidence that you did change behavior or do some good with the intervention, you're not going to be funded repeatedly. So that's a very important criterion for accreditation. Any thoughts on that? Those criteria for accreditation? Any questions? Okay. So what do we mean by learner-centric? Does anyone have any thoughts on this? How would we know if something is or is not learner-centric?
Well, you don't.
I was going to say specific to your target audience.
Mm-hmm. Can anyone give me an example of something that would not be learner-centric? Education that comes from somewhere besides the learner need?
Like commercially supported programs.
Very good. That's very much part of what the accreditation standards address, the standards for commercial support. Back in the olden times, the 90s, often learning was, first originated from a pharmaceutical company that was trying to push out product information. That can result in a whole lot of, pill-specific education, not really looking at fair use and fair balance between competing drugs in the same class. And so the ACCME in I believe it was 2004, said, we really need these standards of commercial support. Just because pharma's paying for this doesn't mean they get to run the show and dictate what the learning is. So a lot of people got their heads together and started to think about what would learner-centric mean, or first had to sort of discover and coin the verb, or the noun, learner-centric. Adjective. And it really describes coming from the need, as we were talking about needs assessment, the need of the learner either expressed or in comparison to a comparison cohort nationally or within the profession. It should have a patient aspect. It should promote an improvement in care, and not a proprietary interest. Certain drug and device makers would love for us to use more of their products, but if it's not actually, helping patients get better, more is not always better. So, and the way you really look at promoting improvements are looking at the actual changes in the learners, their competence, their performance, their patient outcomes, and how closely the program was aligned to its learning objectives. Did it do what it set out to do, or did it go off the rails a little? That can happen, especially in certain interactive formats. And it's not always bad. Sometimes you have missed the need in your needs assessment, and the learners will tell you in the classroom, this is not what we need. We're going to tell you today in the classroom that we need something slightly different. So all of that is good, and all of it is, if you have a way of monitoring and gathering data from that, it's great feedback from the learners. So you want to be a program, we want to be a program, and any accredited provider that has the gold seal, especially we have the upgrade, Winthrop has commendation, and that's fewer than 25% of institutions nationally have that. To get that gold seal, you need to be an organization that gathers data, that uses it, that feeds it back into a planned learning cycle institutionally, analyzing PDSA cycle for those of you that know quality science, and plan, do, study, act. Study being the looking at the data and acting to improve the intervention the next go round. And again, provider just means education provider, not healthcare provider. So, want to go on to interprofessional education and what that really means. I'm glad to see that in this room we have at least 6 professions, or 5 at least, represented, and increasingly that is the state of continuing education. Because most care is delivered in some sort of a team setting, it's important to address the silos that some people feel exist between professions. I know our pre-service training often really gets us to think about our profession and its boundaries. When we get into the care setting, we have interfaces with team members. So interprofessional education is a big trend. This is not to say we're smearing across all the differences between licensure and what people are allowed to do in the clinic, but to learn from, with, and about each other across professions to improve collaboration and the quality of care. Implicit in that is respect between the professions, sort of minimizing some of the hierarchies, although they will continue to exist, but I don't know what that was, but so it generally comes from respect and listening between professions. It's a way of deliberately working together to really improve the system, both where you work and across collaboratives and across institutions, so that care is safer and better, patient-centered, and population-oriented. Anyone have any thoughts on interprofessionalism? Any experiences they want to relate?
That's what we did. We had, like I was saying earlier, we had an hour that was dedicated to CMEs, and the chairman is there, and the stenographer is there, and everyone in between. And they all ask questions and bounce off each other about a specific subject.
That's great.
So it was kind of when Dr. Vincelanos, I should say.
Yeah.
He's there.
Yeah. And what is there some sort of report that comes out of that mixing together learners? Do you record the feedback and have minutes, or how does it go?
We just discuss a specific case.
Mm-hmm.
We have follow-up in later meetings, but there's not really minutes together.
Yeah.
I know my supervisor puts something together and sends it to the CME office.
Yeah. Well, case-based learning is a very, really efficient way of getting a team, because it very much resembles what happens in the clinic with team-based care. People can bring perspectives and frameworks that they use in their own professional thinking. They can share that, and they can throw in feedback. So it's a really great format. So how do you make a piece of continuing education, an activity, more interprofessional or interprofessional to begin with? Does anyone have any ideas on that?
What are some of the barriers that come to it?
Yeah.
You may have,
Yeah,
you may have differing target audiences,
Mm-hmm.
different levels of
primary, secondary learners.
competency.
You have to choose a topic that would address all of the different levels of learners.
Topics, yeah.
Without neutralizing it.
Yeah.
And certain formats can lend itself to that,
In particular.
like tumor boards or
Mm-hmm.
M&Ms or something. They could have interprofessional.
Yeah, absolutely. As well as, scheduling for a live session is always a challenge because people's, clinical schedules differ and you have to consider schedule when planning an interprofessional live activity. Also seating, the way you put your furniture in an education room can really affect whether people will co-participate or just sort of passively audit. So those are some of the things to think about in planning it. But in terms of actually designing your needs assessment, one place to start is to appoint a planning committee that, small enough that people will feel some level of responsibility to the group and attend a planning committee meeting. They don't have to be often or many, but to start an activity, it's always good to have a planning committee that is itself interprofessional and represents the target audience fairly well. Again, we do in our office courses, multi-day courses that may have up to 8 or 10 professions segmented and targeted. Now we don't get them all equally in headcount to attend, but more and more we're trying to include a planner from each of those professions in the planning committee so they can say, we have a different vocabulary for this problem. In my profession, we call it by a different name, or we have a different way of thinking about it. So it's important to include those perspectives. Often, as we have recently witnessed with our state accreditation for social work continuing education, can't really accredit an education if a member of the social work profession isn't on the planning committee. And so, some professions are very strict about that. And some, will do more review at the activity level. For example, if we're getting something accredited for athletic trainers, that gets reviewed by a certification board. So we don't necessarily have to do as much work on our side, but really the accreditation needs to be interprofessional for the activity to be interprofessional. And now let's talk about evidence. It's a big word. And in a half an hour and just maybe a few more minutes remaining, we can't really get into a whole lot of science about what is good evidence and what is not. But why evidence is necessary is because, we really do want care to be evidence-based. So we want the education for care to be evidence-based. While there is a category of needs assessment data known as professional judgment, that is not meant to shut out other evidence that you could use in building an intervention, an educational activity. Especially if there's a lot of evidence available to you, you should use it. And it gets to the triple aim. As most of you probably know, the Institute for Healthcare Improvement has promulgated the triple aim, which is to increase healthcare quality through the experience of care, satisfaction, and improve population health, but also reduce costs. So, evidence is really getting toward toward doing that, and at least gives you a ruler as to whether an intervention will be worth its cost. So where is evidence found? Anyone have any first impression or first inspiration on where they might look to find evidence for continuing education that they may be planning?
Peer journals?
Peer journals, excellent. Clinical guidelines, another excellent one.
How valuable is anecdotal?
Expert opinion.
It's about
Expert
it.
opinion.
I say that only because of the fact that some of you in the room here know that all the faculty development that I've been doing here, when I first came here 5 years ago, putting together a survey amongst our faculty about AIDS assessment, I knew it wouldn't get much of a response, and it didn't. But I felt kind of obliged to at least make an attempt at it. So we certainly know that surveys and getting responses to get evidence, individual basis, probably ain't going to work very well. So you're not going to get much of a response. But the other part about it is too that just by your own networking, you hear what people's needs are, what their concerns are. So as a planner, as an organizer, you think about those things. You get a frequency count going. You figure, well, this seems something's going on here. So those kind of things. And it's kind of low. Let's say low yield, but certainly not very quantitative.
Yeah.
At the same token, I think it has some real value, especially locally.
It could also be more salient than some of the published evidence because, it's a sort of a personally expressed professional need. I'm in favor of casting the widest possible net, between the expert sources, which can be local faculty and literature and some of the published things, but also things that are promulgated by larger groups like CMS and AHRQ, specialty boards. Those are great places to look for really national standards. You can also take evaluation data from a previous learner activity. For example, Diana, in your, I think you said it was a tumor board or Dr. Vinceleos' CME. If the group is doing a written evaluation, those evaluations are a goldmine of what they need in future education and what they'd like to see, and sometimes even, where they feel they maybe didn't do as good of a job in the past with a case because they had a learning gap. That perfect, place to discover that information. You can also, as Jack said, make formal or informal requests of the clinical audience, and it doesn't have to be a huge data set, but it can at least point you out into themes.
Rob, but when you do, when you ask for suggested topics from learners or as part of evaluation, in the bottom it says, suggestion for future topics, I may get one person wants this topic. Do I take into account that one learner's?
It depends on how you frame it, and you actually are just segueing perfectly into our video portion. This is Murray Coppolo, who for years ran the Accreditation Council for Continuing Education. He has since retired, but a couple years ago he was asked this question, and I thought he had a pretty good answer to it here.
It's also important to understand how to use our traditional tools for needs assessment using these 2006 updated criteria. For many, many years, we've stopped docs in the hallway and said, what do you want grand rounds to be on? We've given people documents at the end of an activity and said, what do you want next year to be on? We send surveys around and say, we're building our update for 2010. What should it be and what information should it contain? Now, at the same time, ACCME has published that providers who identify professional practice gaps and needs simply by doing surveys and looking in the literature are not getting compliance. So how do we reconcile these two things? Well, first of all, ACCME wants to know what information you're finding. So when you're thinking about doing your CME planning and presenting it to us, remember, it's not the tool that we're looking for. It's the information that the tool provides. And it's the same in looking at this traditional needs assessment information. When you ask your learners, what do you want something to be in the future, you need to be thinking about framing the question in the context of a professional practice gap. What questions in practice are you having that you are not getting answers to? What patient problems or patient challenges do you feel that you're not able to address appropriately or to your satisfaction? What patient problems are your patients saying back to you needs more attention or more follow-up? So you're using a traditional tool, but the questions that you're asking, the information that you're getting is now in the context of a professional practice gap. Now, the provider can explore the knowledge, competence, and performance themselves, or the provider can explore that with the learner. So if a physician says, I'm not able to recognize a certain diagnosis in my practice, that's the professional practice gap. Asking them, well, why do you think that is? And that they might say back to you, well, I understand the anatomy and physiology and pathophysiology completely. I just don't know what questions to ask. You've got your learners telling you that it's not a knowledge problem that underlies this gap, but it's a strategy problem. It's a competence problem. And you need to listen to those and feel free to respond to those learners of yours to design an educational activity to change competence as a result of the professional practice gap and the information you got from your learners. So very much acceptable to use the traditional tools. It's how you frame the question and the information that you get back and the translation of the gap into a knowledge, competence, or performance problem.
So, sorry, that's, I think, a great recap. Guidelines are evidence, but it's not just the tool you use to get the information, the survey. It's the information within it. And as he said, not only asking what, but asking the learner why. It just gets you a little more information as to where you can go with the strategy. And importantly, as he mentioned, frame the question to the learners in terms of professional practice gap. I see a lot of surveys that say, what do you want to learn? In fact, I think our survey at the end of today says, what could we have done to improve the activity? Well, you're going to get things like air conditioning and food and lemonade and something that's that open-ended. It's good to key it to think of a time, reflect on practice when a need was not met by you as a healthcare provider, and think of why and what was the barrier or what did you need and how can we address that specific moment. Because generally there is representation. If one person will verbalize it, others are feeling it. So I think we don't really have time to go into sort of the quality of evidence questions, but I will certainly email you the slides. I think we have a handout for the rest of this stuff, but I think I'll turn it over to Jack for the worksheet session now. We have about almost 20 minutes remaining.
Yeah, one of the things we wanted to do is give an opportunity for you to actually, perhaps when you're putting a planning document together, and some of the kind of the overarching concepts that you might have. We also, here, we had about the flipped classroom model, okay? And so we're trying to advocate that more and more as time goes on. And those of you that received the article in advance, what's the advantage of using this strategy of having a pre-reading activity before a session? Look, ahead of the game, but you come ready to learn. That's just it. And so, this is just, and I don't use the term trite, but it almost is. I mean, it gives you something here, at least you give you an idea how that might work. A 40-page journal article probably unlikely I'm just going to wind up reading it. But you think in some ways that you can advance offload in many respects, either using technology or some social media or whatever that you might think of to get your learners to be able to come to the session so they're ready to learn, so they can actually maximize the opportunity to be able to learn. So here's an idea for that, and that's, as a matter of fact, that's question number 1 on your handout there too. Is asking you to reflect on the article itself. So we asked you to read the ILD course outline, and so I had just one simple question. What is the most common ILD interstitial lung disease? What's the most common one? Reading the article.
The idiopathic.
Yes, idiopathic. So like I said, it's just a trite exercise, but still gives you an idea for doing that. So it's a way of making sure that your audience actually perhaps reads the article so they can do that. So what are the incentives for doing that? So you think of some incentive that you might have to be able to use this kind of a flipped classroom model to make it interactive as well. And then last but not least is the, so if you want to fill in the blanks here, so whatever program that you are, that you have, be it pediatrics or OB or whatever, think about who your target learners are. So you can write this in. So this is an actual exercise. We can do that now. And what skills or knowledge do you think that they need? That's going to be hypothetical. This is not an actual test, but you think about that a little bit. So actually put that in writing. What are some of the limitations of your learners for a CME course? To do that first, and then Rob, maybe you can share with your partner, and Joe, share with the colleague here too, if you get the response. This is how we learn from each other too.
I'll be your partner here.
So if you were to put together a regular series or a CME course, who might your target learners be? Shouldn't say physicians, but maybe even more specifically, what specialty within or subspecialty that you might want to consider for having some. What skills and knowledge might you think that they need? More electronic medical records or diagnostic or whatever it might be. What are some of the limitations? Time. Don't put down time. Your time. Everybody puts in time.
Yeah. First thing.
That's a universal one, okay. But think of some other limitations that maybe, or ways that
Not enough experience.
you could.
Is experience?
Not enough experience.
Yeah, that's just it. So what are some of the ways that you can mitigate the time challenge?
Well, by making them available through on demand.
Well, that's just it. So maybe using technology in some way or another. So anyhow, we can do this together anyhow. So as an example, Joe, who might be a target audience that you might be considering?
I think it would be our own physicians.
In general, or anything specific subset of physicians?
Pulmonologists.
Yeah.
For me, it's like the community pediatricians, the residents.
And then to make it interprofessional, then you might think of a few technicians, nurses, nurse practitioners.
We have nurse practitioners, PAs.
Yeah, you can broaden it a little bit. I don't know about risk managers, but you never know. It could be something there. I don't know if they only continuing education, probably. But still, to be part of the team, and that's the whole approach to this too. Patient-centered care. Let's take a look then at the gap analysis. So think of an identified problem, perhaps within the context of what you had there for your target audience. It's a tough one here. What are some of the current performance requirements. Well, you might not know that, but they're still out there. And where would you find that information that Rob presented earlier? Some potential resources for you to consider. So how do you know what the requirements are within your discipline to be able to assess what that gap is? And of course, and the best one of all is how do you know the data difference? That's the big challenge. So how do you know that they actually acquired the knowledge, perhaps the skills, or the attitude, and maybe put that into clinical practice? It's a stretch there, but still, knowing what Kirkpatrick, or what's the newer one?
More, Donald
Yeah.
Moore. And we have a special session on outcomes at the end of this series, but yeah, there are definitely levels of outcomes that you can classify your outcomes according to Moore's 7 levels, which is actually 8, because level 3 is 3A and 3B. But it's it's really a good way of classifying the outcome, and it's based on Kirkpatrick.
So, my colleague Ron here knows well, but others may know too that, attending any kind of a class or a workshop or any kind of a CME program or anything like that, and I go back further than most of you when it comes to CME, back in the old days, it was just a matter of if they were satisfied, lighting was good, the interaction was good, the food, these kind of things. Yeah, it's worth something. It wasn't much, but still. But really, what do they learn? And see outcomes there. So maybe, you have a quiz or something like that, or using audience responses. We sometimes use whatever it is, you can measure some tangible outcome that you can actually enumerate, and that comes in handy next time that you have another course, right? Or at least meeting accreditation requirements anyhow. So you have to be documentable in terms of either quantitative or qualitative information that you have. Then the third phase, using the Kirkpatrick method, the third stage is how does that impact patient care? So what you might consider, I don't want to get ahead of us too much here, 6 months later, you send out a query or notice to them. What you learned in this interstitial lung disease course back in November, okay, which of these guidelines are you using in practice? So at least in some way, it has some impact. But otherwise, you'd never.
And at some point, we'll be able to do that through the EHR to ask a research question, and just for a specific data or for a specific diagnostic state, to do a snapshot in time before our activity. This disease state was having these comorbidities, perhaps, and then after our activity a year later, there was a change, hopefully for the better. We hope to get there with the EHR, but that's another way that data.
I mean, this is like what we're kind of doing with. One thing is cutting down the use of antibiotics in patients, pediatric patients with virus infection. So we've been able to kind of look at how many doses of antibiotics together with the pharmacy department, the emergency department, and looking at charts, trying to cut down excessive use of antibiotics.
Yeah, I think that's a great way of approaching that problem, because it's got the data behind it. There's an actual population being studied, and then there's a target audience of learners that's implied by the clinicians treating that population. So, yeah, technology can really help. So, how are we doing on time, Jack? Do we need to?
We've got another 5 minutes. So, why do we go through doing all of this? Well, I think for 2 major reasons I'm speaking here. Because Winthrop is an academic health center. Okay, that by itself would be good enough. But then also, too, it's meeting accreditation requirements. But I think even the third one, the better one, is that you want to feel satisfied that that you're making a difference. I mean, that's basically it, right? So you're meeting needs of your learners, you're using the resources that you have at hand. You're making it something that is perhaps an enjoyable experience, and certainly a knowledgeable thing, but then also be able to get some level of success, to know that you put your finger on, grab a number or something, and say that you've made a difference. And then sequentially, as time goes on, keep building upon it. And so, as a professional, it's something that I think we're all concerned with. You want to do a better job, and how can we do that? And especially when you're involving your team in terms of planning, activities and whatnot, it's got many other benefits to it.
Do you have a question, Rob?
Yeah, in terms of, like planning like a RS activity, like sometimes there's, it's like even within the department, they want you to schedule faculty as a way of promotion. So it's not really based on learners' needs.
That's a very good insight. I'm glad that you said that and not me. No, because that is an observation that I've had not just here, but elsewhere. Sometimes you just want to. It's driven by a faculty need, perhaps more than a learner need, although they're not necessarily completely divorced from each other. They can be together, but. Yeah, that's a very tough spot to be in. The standard for accrediting RSS is a little bit looser than it is for symposium, but generally there are sort of longitudinal factors to consider, and I'd like to plug Jack's great modules that we have on InReach, in particular sequencing a CME series. That really talks about if you're responsible for a whole year of grand rounds, how can you make that really productive for learners, assuming that they attend all of them and not just sort of sampling. This brings us to some other resources, that you can use in addition to these 7 courses, which I hope you all will consider coming to more of throughout the summer. But also consider going to InReach and viewing Jack's 2 modules on designing effective courses and instruction. Great resources. They're free. You don't have to pay. We'll continue with what the next step in the cycle is next week's session on learning objectives and how to write them and how to make them really fine-tune them so they're measurable. And then throughout the summer, we'll get through the rest of the CME life cycle. And by the way, if you're planning a symposium, I just want to give a commercial for Peter and myself. Start early. 12 months is not too early to start. 6 to 9 months really is the minimum. And that's mostly because any grants we would go after for you are going to need a lot of lead time. So any final thoughts, Jack?
Yeah, just be sure and if you come to the next session or subsequent ones that you promote to your colleagues and others to attend too, so that you become more, well, not you individually, but collectively, become more self-directed in terms of putting applications together. Rob and Peter have done a great job in promoting so many of our wonderful courses and symposium, but it starts with you in terms of organizing. Really makes a big difference in terms of productivity. So the more self-directed that you are in doing this, I think it's better for the institution as well.
Yeah, because really it's you all that have your pulse on the learner needs, much more so than our office does at Summer Move. So thank you all for coming, and I'll be emailing you a survey this afternoon for the session.